welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our first presenter today is going to be Allan Davidson, a PGY2 emergency medicine pharmacy resident at Hackensack University Medical Center. He'll be presenting on factors in the initial resuscitation of patients with severe trauma, the FiiRST-2 trial.
So for our learning objectives, by the end of this presentation, you should be able to outline the initial resuscitation strategies for trauma patients with significant blood loss, understand the pathophysiology and management strategies for trauma-induced coagulopathy, and finally, evaluate the FiiRST-2 randomized controlled trial investigating the empiric factor replacement in patients with severe trauma. So just to start off with some background, in the resuscitation of patients with severe trauma, patients with signs of hemorrhagic shock may require aggressive volume repletion with blood products, commonly referred to as massive hemorrhage protocol, or MHP. And MHP generally consists of transfusion of red blood cells, platelets, and plasma, ideally in an even ratio. And you should supplement IV calcium empirically, and that's to account for the citrate content in the blood factors that may precipitate a coagulopathy when given significant product volume. And you should also minimize crystalloid fluids in these patients because the administration of high volumes of crystalloid will dilute out some of the clotting factors that are in the blood that may also worsen coagulopathy. And trauma-induced coagulopathy is a complication that is fairly common, around 25% of patients with severe trauma. And the pathophysiology generally consists of disruption of the clotting cascade through multiple mechanisms in response to trauma, either increased fibrinolysis or decreased clot formation. And those pathways are summarized in the graphic here to the right. And this phenomenon is also exacerbated by hypothermia as well as acidemia, which are both also common in trauma patients. So I mentioned previously that generally for MHP, you administer products in an even ratio. But if you are able to determine a patient's specific coagulation deficiencies, you should guide your resuscitation to target those specific deficiencies. So your product selection might be guided by certain lab values like PT, INR, fibrinogen, or platelet levels, or by more dynamic measures such as the thromboelastography or TEG, or the rotational thromboelastography or ROTEM. And these analyses will not only show you how quickly a clot is able to form, but also the strength of the clot and the degree of fibrinolysis. And for those of you that may not be as familiar with ROTEM, you can think of it as very similar to TEG, almost analogous. It's just a slight proprietary difference, but it gives you the same information in real time at the bedside, and you can think of them as interchangeable for the purposes of this presentation. Here's a quick summary of the different blood products and clotting factors that we're going to discuss through the remainder of this presentation, including relevant acronyms, the contents of these factors, as well as their formulation and storage. And just to highlight a few key differences. So most of our blood products that we're familiar with come in IV bags that have to be stored in the refrigerator, but some of our concentrated products like fibrinogen concentrate can come as a powder that can be stored at room temperature. Similarly with the 4-factor prothrombin complex concentrate can also be stored at room temperature. So that might allow for certain logistical advantages over some of the other products that have to be either thawed or stored in the fridge. And just to give a quick review of some of the relevant background literature, the REDIC trial was a single-center, open-label, randomized control trial looking at adult trauma patients with injury severity score greater than 15 and signs of bleeding with coagulopathy that was diagnosed with the ROTEM analysis, again, similar to TEG. And patients were randomized to receive either FC fibrinogen concentrate or 4-factor PCC prothrombin complex concentrate based off of the results of their ROTEM analysis. And the control group just received fresh frozen plasma, FFP. They found for the primary outcome of multiple organ failure, which they identified using the SOFA score, no difference between the two treatment groups. And they also did terminate the study early due to safety and futility concerns, those safety concerns being more patients in the control group requiring rescue therapy with FC or PCC, and greater patients in the control group going on to require MHP. So the authors of the FiiRST-2 trial that we're going to get into a bit later, based off the results of this study, hypothesized that administering both of these products empirically, both FC and PCC together, earlier in a patient's treatment course may result in better outcomes. And then while the FiiRST-2 trial was taking place, there were 2 other studies that were published in the interim that were very similar. So I'm going to review those briefly just to be able to compare and contrast them. So the ProCoag trial was also a double-blind, randomized, placebo-controlled superiority trial, and it looked at adult trauma patients that were at risk of MHP, and they were randomized to receive either PCC or normal saline as a placebo. For the primary outcome of the median number of blood products required within 24 hours, they found no difference between groups. They did find slightly more thrombotic events occurring in the patients receiving PCC versus placebo. So in summary, there's potentially doesn't seem to be much of a benefit associated with PCC in this population, but potentially some risk of harm. And the other study that came out while the FiiRST-2 trial was being conducted is the FiiRST-2 trial. This was a multi-center, randomized, open-label, parallel-controlled study in trauma patients requiring MHP with hemodynamic instability. These patients were randomized to receive cryoprecipitate, which is a concentrated fibrinogen product, at 6 grams fibrinogen equivalent. And just for context, that equates to around 15 units of cryo, versus the control group receiving just the standard MHP protocol at their site of treatment. For the primary outcome of all-cause 28-day mortality, they found no difference between groups, and for their rates of thromboembolic events, they also found no difference between groups. So in summary, this study found really no difference in efficacy or safety using a concentrated fibrinogen product as cryo. And that brings us to our study, the FiiRST-2 randomized controlled trial, looking at the factors in the initial resuscitation of patients with severe trauma. The objective of this study was to evaluate the replacement of clotting factors with FFP versus FC plus PCC in the initial resuscitation of patients with severe trauma. This was a multi-center randomized controlled superiority trial conducted at 6 level 1 trauma centers in Canada from April 2021 to February 2023. Patients were randomized by the blood bank technologist using a permuted log random allocation. Patients were included if they were at least 16 years of age, with traumatic injury requiring MHP activation with one hour of presentation. Patients were excluded if they received at least 2 units of red blood cells before MHP activation, if it had been more than 3 hours since their injury, if they had incurred a penetrating brain injury with a GCS of 3, or if they'd received anticoagulation within 7 days. And the remaining exclusion criteria listed for your reference, these patients were excluded just because they might have indicated a different treatment modality other than the FC and PCC. So once patients were randomized, they received their study medications within the first 2 MHP packs. And I made this little graphic on the right to sort of summarize exactly what was in each of those packs. So both groups received in their first pack 4 units of red blood cells in addition to the treatment that they were randomized to. So for the intervention group, that was 4 grams of fibrinogen concentrate or 2,000 units of the prothrombin complex concentrate. And then the control group received just 4 units of FFP in addition to red blood cells. And then in the second pack, those contents were the exact same as the first pack, just with the addition of the 4 units of platelets. Contents of any additional packs were determined by the standard treatment protocols at the site of treatment. And then patients in the control group were allowed to receive fibrinogen concentrate if their fibrinogen level was low, below a threshold of 1.5 to 2. The primary outcome of the study was the mean number of blood products transfused within 24 hours. And secondary outcomes included the mean number of blood products, but excluding the units of FFP that were administered in the first 2 packs. And the reason that they wanted to look at this specifically is just to account for the volume difference that's inherent between the 2 randomized treatment groups. They also looked at the individual blood components that were transfused within 24 hours, the use of rescue hemostatic agents after the second pack, the days out of hospital at 28 days, as well as 24-hour mortality, all-cause 28-day mortality, and time to death within 28 days. Safety outcomes included the incidence of thromboembolic events within 28 days, as well as ventilator-free days at 28 days and ICU-free days at 28 days. And lastly, they looked at multi-organ failure and abdominal or limb compartment syndrome. For their statistical analysis, primary analysis utilized a modified intention to treat model that excluded patients that were randomized but did not actually receive their treatment. For their power calculation, they determined a size of 297 patients were required to achieve 80% power to detect superiority with a preset alpha of 0.025. So superiority would be determined if the upper bound of the 97.5% confidence interval was less than 1.0 for the primary outcome. And analysis of other outcomes utilized an alpha value of 0.05. And lastly, they pre-planned an interim analysis using the first 120 patients with a predetermined futility boundary with conditional power of less than 25%. So they ended up screening 439 patients and randomizing 217. And then after excluding patients that ended up not receiving their treatment, there were 66 patients included in the primary analysis for the FC-PCC group and 71 patients for the FFP group. And then at this point, they conducted their interim analysis with the first 137 patients, and they did find a conditional power of less than 25%. So at this point, the study was terminated early for futility. And now moving into the baseline characteristics, they did not perform statistics on this data just to compare them qualitatively. There were similar baseline characteristics between groups. Notably, the majority of patients in both groups were male. Blunt mechanisms of injury were more common than penetrating injury in both groups. The injury severity score was similar between groups. And of note, the median GCS score in the two groups was a little bit different. So GCS is a measure of mental status ranging from 3 to 15. Scores of 15 are correlating more with better mental status and lower scores with more poor mental status. And that would also correlate potentially with injury severity or potentially with the mechanism of injury if there was a head injury involved. So the FFP group had a median GCS of 10 versus 14 in the PCC group. And I think that would be a clinically significant difference as well. So this may mean that the FFP group had more severe injuries at baseline or potentially more common with head injuries. So that may affect our interpretation of these results. And then moving on for baseline characteristics, the majority of patients, around 90% in both groups, received TXA empirically. And INRs I have listed here for reference as well. This study decided to use a threshold of an INR greater than 1.2 to determine patients that were coagulopathic. Other studies reference a threshold of 1.5, so I've included both for reference. But for their threshold of 1.2, just over half of their patients were deemed to be coagulopathic by that definition. The majority of patients in both groups also had a normal fibrinogen level and a normal platelet count. Then moving on to results. So I've highlighted at the top in the black box the primary outcome. So for the mean number of blood products required within 24 hours, the average was 20 to 23, and no difference was seen between groups. And I also wanted to highlight that the median for the blood products required within 24 hours was significantly lower, around 11 or 12. So I think the difference between the median and the mean here might indicate that there was not a normal distribution of data. Potentially a smaller subgroup within each group required more blood products than the remaining patients in the group that may have driven a difference between the median and the mean. Similar results were seen for the blood products excluding the FFP units, and also no difference was seen in the individual blood components that were required. There was a difference in the frequency of rescue FC therapy within 24 hours. This was more common in the FFP group at 59.1% compared to only 25% in the FC-PCC group. That was the one outcome that was statistically different. And then continuing on to the remaining of the results, for the days out of hospital, there was no difference between groups. Similarly with the ICU-free days and ventilator-free days. The FFP group did have a slightly higher 24-hour mortality rate and all-cause 28-day mortality, though those differences were not significant. And the FC-PCC group had slightly higher thrombotic events, but also not significant. So the authors concluded based off of these results that the empiric use of FC plus PCC versus FFP in severe trauma patients did not show any benefit in the primary outcome or secondary or safety outcomes. And wrapping up with the discussion, the strengths of the study, it did have a fairly robust and pragmatic design that would potentially mimic real practice. The design did prioritize early administration of these medications, which in theory might be where we would see the most benefit. They also did focus on patients with more severe trauma requiring MHP, which again might be the patients that would have the most benefit. There were significant limitations, however. Notably, the MHP activation criteria did vary between sites. Some sites used more objective criteria like the requirement of blood products or hemodynamic measures, while some sites just used provider opinion. Also, around 90% of patients ended up receiving TXA empirically, and this may potentially limit generalizability to certain facilities that have different practices. For example, a facility that has early access to TEG or ROTEM may opt to use less empiric TXA in favor of waiting to see the results of those studies. that may be slightly different depending on your practice setting. This study also did not use any viscoelastic testing, so no TEG and no ROTEM. Similarly, may not be as common in certain hospitals, but hospitals that do have that resource may choose a different practice. They also did not describe their calcium supplementation strategy. As previously mentioned, it's important to supplement calcium in patients receiving a lot of blood products, as that citrate content could potentially cause a coagulopathy and potentially worsen outcomes. So maybe patients that got less calcium did more poorly, but that information wasn't reported. And then, of course, the FFP group having the lower GCS scores, that could potentially indicate that they had more severe injuries at baseline, or potentially were more common with head injuries. And then only 53% of patients had an INR greater than 1.2, which was their threshold for coagulopathy. So the theoretical benefit of giving these products early would be to address any trauma-induced coagulopathies, but a good deal of their patients did not actually end up having a coagulopathy. So it's possible that the patients that did have higher INR might have received more benefit. And then greater than 50% of the patients in the control group ended up requiring FC rescue therapy. So that does affect our ability to compare these two groups. And then lastly, the study was terminated early for futility, which limits the sample size and the information that we're able to gather from these results. So the key takeaways from today: trauma patients are at risk of trauma-induced coagulopathy and may require supplementation of clotting factors to achieve hemostatic control. But the first two trials demonstrated that the empiric use of FC and PCC versus FFP in the initial resuscitation of severe trauma patients receiving MHP does not really improve patient outcomes. So thank you everyone for your attention, and with that, I'll take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.